And it's a pleasure for us to welcome along this panel Professor Alain DERVAUX, who's going to come in immediately after my introductory remarks on borderline personality disorders, psychotrauma and addictions. And then Léa MONTAGNIer is going to present a current project called Psychotraumaddicto, which is funded by the Foundation Against Addiction. And the title is to open up practices to improve accompaniment and health and care, the first data from the experiment. And then we will continue the presentations with Professor George Bruce from Clermont-Ferrand. And his thing is about recommendations for tomorrow. The bad news is that Sylvie MOLENDA from the National Center of Resilience to Psychotrauma has not been able to join us for personal reasons. And so I suppose the good side of this bad news is that we'll have a bit more time for our presentations and, above all, more time for discussion, because I think that that is an important point. Just a few words to start the session. A lot of you were no doubt here this morning in the plenary session, certainly the second plenary session, where the professor from the University of Pisa gave a general presentation on the basis of their work on dual disorders, trauma and the disorders connected with the use of heroin. A certain number of points showed just how much this question is not just a theoretical question, which is of interest for practitioners and clinical staff, but it's also important to see what care we can give to people who suffer from this dual disorder. I am Jean-Michel DELILE. I'm a psychiatrist. I work in Bordeaux. I'm president of the Federation on Addiction, and my interest in this dates back a long way, because it was back in 2004 with my wife, Myriam Cassa. We published the first ANIT survey, which was funded by the INSERM, the French National Medical Council, on epidemiological data on mothers who were heroin addicts and what was the future of their children. It was a national sample and involved 300 children. This study showed one thing that we did know from the international literature, but we hadn't perhaps measured on a national scale, is that these mothers who sometimes had difficulties with regard to their children themselves very often had separations in their background, and we proposed an American questionnaire on trauma translated into French, and this showed that 2/3 of these women had suffered from aggression or trauma during their childhood, and 1/3 had psychological, physical, or sexual attacks. So the data was very concerning, and the logic at the time was not fully taken into account by the specialized Center for Care for Drug Users. And very often there was a fear of tackling the question of trauma in the background, because there was a fear that that might reactivate anxieties and recall difficult situations without having any way of responding to those effectively. So that was the kind of prehistory of the project that will be presented in a moment by Léa. Since then, of course, things have moved forward very much with George Bruce in particular, and all his team worked on the guide for psychological disorders and addiction. It can be downloaded free from the Addiction Federation site, and so you can get the guide there. And it was one of the guides, the guide, which I think has been the most downloaded. We can see that these questions of comorbidity of psychological trauma and addiction and so on is a major issue, and people who are working on addiction in various sectors, but also in terms of mental health. And then with Georges, we said that the National Fund for the Fight Against Addiction put out a call for tenders and to look at the issue of these dual problems of trauma and addiction, which could respond to the most urgent expectations and requirements of our colleagues. And then, of course, the issue of post-traumatic stress disorder came in. The first reason is that with the addictions that we were working in when we're working in a hospital, the addictions that we see are generally severe addictions, where very frequently there's psychiatric comorbidity. And when you look into that, very often we can see that beforehand there'd been trauma in the past. And in terms of mental health, this was the period, and I think it's still a period, where we have psychotrauma units being created regionally within university hospitals. And there was an expectation there, too, in terms of public health, to promote better skills and knowledge and practice with regard to psychotrauma. So, comorbidity in this field is, of course, very substantial for reasons that Professor Marie-Mani mentioned this morning. I can summarize just in a few words. There's first the self-medication model. There's a post-traumatic stress can lead to self-medication so that people can use psychotropic medicines to have some calming or soothing effect and to sleep better. And the other thing that we can see that sometimes works in the other direction, somebody who is an addict and who has substance use disorder can have a life which would expose him or to a repeated risk of having trauma of one kind or another, violence or whatever. And so it works in both directions. And above all, what we heard this morning, again, I think an essential point, which we'll no doubt come back to this afternoon with Professor DERVAUX's presentation, we can see that a lot of the people presenting this comorbidity had already had various events during their childhood, been exposed to trauma, and we know that this exposure at an early age is a risk factor both in terms of post-traumatic stress and addiction, so that the factors that we're looking at in the background, which can be shared, hypersensitivity to stress sometimes, after early exposure, it's fairly understandable that people should present this kind of associated disorder. Could go perhaps even further than what was said this morning. One of the points which is very striking, and I think this is why with George and other people, and in ATHS I was able to hear Miguel Casas from Barcelona, who was one of the founders of thinking about dual pathologies in the International Association. And he would always say that from his point of view, it wasn't just comorbidity with negative interactions, but there was also a kind of community of development which meant that it was a specific entity, and particularly in terms of symptoms, because when somebody wakes up at night with a heart beating fast, with damp hands and the hypothalamus and adrenal gland is over operating, there's a mechanism maybe of actually withdrawing from alcohol or other drugs. It's very similar. There's a community of symptoms, and again, as was mentioned this morning in a question from the floor, a certain number of therapies need to be shared, need to be common. So this morning we were talking about amiothazepine, which was again mentioned this morning, a specific drug, but we can see that therapies to deal with exposure are beginning to be interesting, and particularly with regard to craving and addiction. So there's something here which points to integration with symptoms, and we have professionals, particularly in addiction, who often were not very aware of post-traumatic stress disorder. But now that's changing, and in terms of mental health, there are difficulties identifying addictions, which sometimes seem secondary or even consequences of problems of self-medication. And I think if you can deal properly with post-traumatic stress disorder, then we might be able to deal with the whole situation. But I think we need to give priority to integrative approaches. So I wanted to just say these few words as introduction. I'd like now to hand over to Professor DERVAUX to talk about borderline personality disorders. Thank you very much for this introduction, and thank you, George, for having organized this, this panel. There are a lot of things that I'm going to say which have already been said, but not necessarily in the same way this morning, particularly regarding psychotrauma. Addiction and psychotrauma, hyperduality is the title. And I think it goes beyond this because we have patients who have several addictive disorders and several psychiatric disorders. And all of these will be embedded and interlocking in the development of these individuals because it's a process which begins in childhood and adolescence. So I'm going to talk about borderline personality disorders, psychotrauma, and addiction. And I'm referring to the international classification. In research, we use DSM-5 for borderline personalities and CIM-10 that we all use in hospitals and so on to code the diagnosis of patients, what we call emotionally labile personalities are borderline. In CIM-11, there's an extra dimension, and that is that the approach is dimensional. It hasn't yet been published in French, but it will be published. This is light disorders, medium disorders, and severe disorders, because it's important, I think, when we're talking about borderline personalities. Sometimes it's rather a caricature that's offered to us. And the patients that was presented this morning by Moise was a bit of a caricature. A patient who has a borderline personality disorder, which is very typical, a caricature. But all patients that have borderline personalities don't necessarily reach the same intensity in the symptoms. And I was aware of this sometimes because people, outpatients, who, when you look at all the criteria, they see things in black and white. They have a certain emotional intensity. And even if there's not a clinical diagnosis, it's because there's less intensity. So we underestimate. What are the references for that? Take the DSM. There are 5 criteria amongst the 9, very quickly. And instability of interpersonal relationships with cleavage. People see things in black and white. Things are either all good or all bad. And what is good is what provides what I want, and everything else is bad. The third thing is a question of who am I, and I don't know is the answer to that. And on my own, I can't work it out. Fourth criterion is being impulsive. This is a very important criterion because impulsiveness, I think, is Pierre Dac who gives the best definition. It's the person who shoots first, thinks afterwards, and then thinks about what he's done. So acting before they think, that's in being impulsive, not only in terms of addiction or substance abuse, but in other cases, if I look at the TCA, then that could suggest this kind of diagnosis. And repeated behavior or repeated actions, threats of suicide and so on. The sixth thing is affective instability with ups and downs in people's emotional life that they cannot manage. A feeling of emptiness or boredom, sudden and violent anger. I think sometimes they are meaningful. And the last one is transitory occurrence in stress situations of ideas of persecution or other symptoms. So the example I give to describe this is, darling, could you take me to the supermarket this afternoon? Because I'd like to change all my clothes. And somebody says, no, I can't do that. So I have an appointment with a doctor. No, you have an appointment with a doctor. I'm just asking you to take me to the supermarket. And he says, well, I can't. Why can't you? Well, you're a bastard. Because you don't love me. Yes, well, I'm telling you, I can't. No, it's because you don't love me, you bastard. So it's always been like that. And you don't love me, and you've got a grudge against me. And progressively, this is what can happen, and ideas can appear which can reflect this sense of persecution. So what is the frequency of borderline personality disorders in the general population and in the population of patients? In the general population, It's between 0.7 and 2.7% of the population. There's a very fine review of the literature in a recent article of the JEMA. And in the population of patients who have addictions, it's much higher. It's 16%, 4 times more than in the general population. For people who depend on alcohol, DSM-4, with dependency on cannabis, it's 22%, it's very high. People dependent on other drugs, 30%. So these are very, very high figures. And we know that there are a lot of people who have personality disorders or borderline disorders that come for consultancies. But there are more than we actually think. We tend to underestimate the numbers. And these borderline individuals are not only suffering from addictions. In the same review of the literature, they also present the fact that there are a number of other comorbidities, not just dual disorders, but these other issues. A high number of them are bipolar, 10%, have bipolar disorders, 10%. Mood disorders are very high, more than 80%. Using substances, you can see the figures there. Post-traumatic stress disorders, about 30%. And other disorders of the personality, 53%. You didn't also notice TDAH, that's between 30 and 60%. So you can see when you have to manage individuals, patients who have substance disorders and personality disorders, borderline disorders associated with other personality disorders, we have here a whole number of comorbidities. It means that necessarily the management is going to be more complex and will require an integrated approach. In clinical terms, what does that mean? In practice, it means that we have people who have intense emotional reactions which fluctuate very rapidly, with cognitive patterns, with a relationship with the world which will preferentially be of the form, nobody loves me, and I will always be rejected, whatever happens. That's the kind of pattern that is preferential as a background belief that infiltrates all the behaviors of these individuals in a prolonged fashion. And also quite predictably, there are people who live very much in the present time, who have a time frame which is different from ours. Our time frame is perhaps a distant past, a close past, a close future, distant future. These patients, and this is what they share with other people who are psychopathic, is they're always in the present. And in management, we operate with therapies which have a clear timeline. We have first kind of management and then hospital and so on. But this is always very blurred in patients' mind. They live in the present, particularly when they're suffering, rather like little children who have some pain and think that it will never stop. Now, what characterizes these patients is that you see them in situations of crisis. And this is, for example, you're working with the CMP and it's on Friday and it's 4:45. And the office closes at 5. And then the door rings and somebody says, "Doctor, you have to come quickly because there's a serious emergency. I'm going to commit suicide and I need to be sent to hospital immediately." But, you know, it's Friday evening. I've got to go and get my children from school at 5:15. If I'm not at school by 5:30, then I have to go to the police station to collect them. So it's a difficult situation. How can I manage this kind of situation? So in these crisis situations, often with sometimes massive consumption of substances, it's an inextricable situation. And these people are right on the edge and they need to be treated immediately. They require immediate attention and hospitalization to shelter them. But they also demand that they are free to act. And I say, yes, you understand. It's a Friday evening. It's a bit complicated. If I have to go to hospital, it'll be in a psychiatric hospital. And he says, no, not in a psychiatric hospital. I've just come out of the psychiatric hospital. And you say, that's what you have to have. And so, oh, no, I want to go to the Clinique Bellevue because they're they will be properly treated. But it takes a certain amount of time before you can get into the clinic. And they say, no, no, that's where I want to go. Okay, so it happens you know somebody from that clinic, and you phone, and they say, yeah, well, somebody's just dropped out of a therapy, so maybe I can keep a place for you. And I can say, yeah, yeah, fine, that's fine. And you say, I found a place for you at the Bellevue Clinic. And he says, no, but I can't. It's not possible. Who's going to look after my dog? I can't go to hospital because of my dog. And so on and so forth. So this is what happens. They put you in a position where you have to take action, but when you do, it doesn't work. And they demand very much this ability to act on their own initiative. And so that is the node of the approach that we have with these individuals. They can be seen through suicidal activities or self-mutilation, self-mutilation. They can have all kinds of different aggressive behavior, irritability, and so on, sometimes all at the same time. So I've just started drinking. It's impulsive. I just keep drinking. Or somebody says, I woke up in a place that I don't know, and I don't know what I did. So I say, I don't know what happened. So this can be designed to attract attention, but for us, straight away, we have to come into a very complicated system because they take all of our attention, and our attention is also sometimes we have attitudes of overprotection or rejection, because sometimes they create very difficult situations for us, like the one I've just described. But they're like little birds who've just fallen from the nest. And we want to help other people. That's why we do the job we're doing. So little birds that are fledglings that have fallen out of the nest, we want to look after them. And as they put us in situations which are really difficult to deal with in our personal lives, this can lead to counter-transference phenomena on our part. It's important to understand that these addictive behaviors, when they do occur, are often compulsive, massive intoxication, and can be observed often after conflictual interpersonal situations, particularly in situations of a major threat, which often awaken or lead to a memory of other situations in the past. And sometimes this leads to a lot of alcohol, drugs, or medication, like benzodiazepine and so on, which are used outside their proper use situation, and often a mixture. And so what they want is a quick fix to anesthetize the emotions that they have, those inextinguishable emotions, and which are described as impossible to cope with, and that require immediate action. And of course, they have an extremely fast psychotropic effect, but that, in actual fact, aggravates things. For a long time, I followed up a patient, a great borderline, and to illustrate what he was saying, he told me this. He said, if for his whole life, I started to see him when he was about 50. Throughout his life, he wanted to look after children and so on, but that was never possible, because whenever he met a woman, he invited the woman somewhere, and then as soon as there was any suggestion of a possible relationship, he was flooded by the memories of sexual abuse that he had suffered from many years before, and he remembered that, as is generally the case, in a sensory. It's not a narrative. I remember that somebody did this, that, or whatever, but they're reliving the images with the colors, and he remembered the noises that were there when this happened and so on. And it's quite classic in cases of post-traumatic stress. And it was so difficult for him to cope with that he took massive doses of alcohol and other substances, and of course that relationship suffered from that, so he was never able to establish a durable relationship. And so that just made the problem even worse. And it took 6 months before he could actually tell me that when he thought about this carefully, what he felt at that time, he'd never been able to express himself, was a feeling of shame and guilt, that he'd never been able to do what was necessary to reduce his kind of self-sabotaging behavior. So these are things that you see often when you follow people up long enough. What you see are memories which are very intense, and in their real life, there are memories that recall older memories, and then that's when you have compulsive consumption, which can be very important, very significant, very large amounts of alcohol or other substances. What are the factors that encourage addiction in borderline personality disorders? There's impulsiveness. Other people have already talked about this, so it's a criterion. Acting before you think is a key factor, and we know that it favors this kind of addictive behavior, and it can lead to a kind of vicious circle. The more impulsive you are, the more you're at risk of addictive behavior, and the more you consume these substances, the more impulsive you become. So it's one of the vicious circles that can encourage addiction. And then deregulation of the emotions, and several speakers mentioned that this morning, which also characterizes the patients with borderline personality disorders. It's a kind of up and down movement of the emotions with high points and low points, and that goes with alexithymia. And individuals have difficulty identifying their emotions. They are reliving the trauma of the past, but at the same time they're unable to verbalize, to turn it into a narrative. And this means that they have moved a lot forward in their road towards this borderline personality. So they're invaded, flooded by, overwhelmed by emotions, but they're absolutely emotions that they cannot cope with, and they require something to be done immediately, now, straight away. And it's a recourse to substances. There's also one of the colleagues, Otto Kallenberg, one of the inventors of the concept time limit of borderline characteristics. Somebody still working in New York at the university said, to describe that, borderline patients have difficulty reading others and themselves. All of these feelings of shame, anger, greed, rejection, fear, love, rage, they gradually are identified as features in this borderline personality. And unfortunately, there are some secondary effects. This is a fine sentence too by Philippe Jamet. Addiction gives an individual the feeling that they found a base for safety which is available, reliable, and avoids confrontation with feelings of rejection and injury and so on. The fear of being abandoned, being mistreated by others is so great that with alcohol, you know what's going to happen, and cannabis and drugs, you know what the effects are going to be. The post-traumatic stress disorders are an independent risk factor for addiction, but they're particularly frequent in borderline patients after all kinds of mistreatment. Mistreatment, poor treatment could be all sorts of things, all forms of mistreatment. We know that mistreatment is very frequent in our patients who have addictions. Epidemiological studies show that it's even more frequent because these are things we don't always identify. It's not something which you can see when you're just seeing somebody quickly at an accident and emergency department. But you need to have sufficient confidence so that they can tell you things that very often it takes years or even tens of years to actually express. So these mistreatments, of course, we think of sexual abuse, and all kinds of sexual aggression, but also physical mistreatment, children who've been battered, also psychological mistreatment. A child who throughout his life has heard, you're no good, you'll never succeed. When you've heard that kind of thing throughout your childhood, a lot of parents sometimes say this kind of thing to children. It's not even considered abnormal. It's considered as something normal. So they don't necessarily point this out when they see you because they consider it as something normal. But that's certainly something which needs to be actively explored because they just think it's normal. Emotional negligence. You can see that in children of executives in the rich areas. And that doesn't mean that you don't have other kinds of abuse, but this is particularly the case. Parents who are cold with their children. They say, now you're a big boy, a big girl, or whatever. And I've seen this, and you just have to sort of deal with that yourself. So yes, you can sort this out yourself. And then, of course, they do sort things out themselves. They begin consuming drugs. They're beginning dealing. They start at 16 or thereabouts, and they move on from there. So there are a whole series of examples like this. Some time ago, I saw a story about an artist currently exhibiting in the Tokyo Palace, telling the story of relationships with her mother. Her mother was a big bourgeois woman who sometimes said, everything was fine. The girl wanted to go and kiss her mother. Her mother gave her a little peck on the cheek and said, "I'll see you later." That kind of thing. That's what we call a kind of psychological mistreatment or neglect, being neglected. There's not the right sort of care. There are a lot of cases like that. And once again, these individuals don't necessarily see that as pathological. They think that it's like that for all children. But although they can see that some children have a different experience, but they are asking for love and they don't get it in return. So all of these traumatic individuals, these traumatic events are things that these individuals relive. And then you can sometimes have dissociative symptoms. And you can see that in acute stress moments. It's a way of coping with emotional pain, or the emotional side of pain. And this psychological dimension is so important that it means these very painful affects can be held at a distance, and perhaps you could say these individuals are trying to relive these dissociation symptoms to be able to cope with that psychological and emotional pain. And we know now that there's a neurobiological correlate, the work in Atlanta and Tasha in Chicago, who showed the entire chain and showed that when you are subjected to repeated stress, in childhood in particular, this chronically activates the hypothalamus and so on, all these systems, and you can see that this could lead to cerebral toxicity because too much pain is toxic for the nervous system. And this has been shown to lead to, in the amygdala, the emotional memory, in borderline patients, there is hyperactivity of the amygdala because of stress. Whenever you get a moderate stress, these individuals will overreact very strongly. So unlike normal individuals who have a sufficient emotional capacity. But this hyperactivity is another risk of addiction with the adrenal system, because everything which activates this stress system is going to encourage dependency. Difficulties of attachment, no. As the rule rather than the exception, it favors addiction. And you will have patients who are going to be insecure, disorganized, with completely disorganized narratives. Recently, I was supervising some colleagues for some university research with patients like that. And it took hours to reconstruct the story of a patient because it was so chaotic. Usually we know the story. This is what happened when they're 13, for example, first consumption of alcohol, compulsive drinking, aggression, and so on, as you said. As they drink a lot, and they're more vulnerable to other aggressions and so on. It's, again, a vicious circle. There's pressure, there's hospitalization, care given in various different places, and it's not a continuous chain. There's continuous breakages in their experience. And as I'm working in different places, I can sometimes see how sometimes individuals like that can move from one institution to another. People have big problems, for example, of alcohol and cocaine, go to another university department, and they go just to look at addiction to things like Stimox and so on. And they don't say that they're being followed for alcohol and cocaine addiction in another institution. Again, that's a case of what we call cleavage. And these discontinuities in care are something which we see very frequently with this kind of person. So this makes it very difficult for us to have a clear vision of things. The good news is the changing aspects of this. There's an evolution. We've had some studies of cohorts of 300 borderline patients. And these studies show that when they are treated, then their future is very favorable. The outcome is very favorable with regard to their addictive activities, their food practices, and so on, and their symptoms. Overall, if you look at the long-term change in borderline subjects over this period of 16 years, 50% of the individuals have an improvement, and 90% have had at least one period of complete remission. The idea in the 1990s, people said personality disorders, they say you can't change that. Because if you change the personality, you have to change the structure. And as you can't change the structure, we can't deal with it. So there's no point trying to cope with it because we can't change the structure. In the 21st century, we're trying to approach this differently. You're not going to change the structure. It's not desirable. It's not ethical. So the goal of therapy is not to change people, but to help them to have a less conflictual relationship with others, have a more serene approach to the outside world, and to perhaps treat their depression and their addictions and so on. When you do look after them, you could see that clearly here in green. After 6 years, instead of having 50% of alcohol disorders, you only have 11% of alcohol use disorders when the patients are treated. And this brings us now to therapy. And I hope I'm not going to say too much what you're going to say, and I've got just 3 more minutes. This is integral management. In terms of addiction treatments, it's integrated management, psychotherapy, and pharmacotherapy. In terms of pharmacotherapy, the treatment that's used in addiction can also be used with no problem. It could be agonism, or those medication that can help stop drinking or smoking, and so on. With benzos, there's a lot of appetite because very often there are issues there that need to be worked on from a psychotherapeutic point of view. A lot of work has been published recently on the management of borderline patients and what is the interest of medication. One is to deal with the psychiatric disorders that are associated. There are all sorts of associated psychiatric difficulties. So a lot of them can be treated by drugs and so on. When you have associated emotional symptoms, or when you have psychotic disorders, for TDAH, That's another issue. What do we do? For the moment, there's just expert opinions, because for the moment there are no recommendations. That doesn't mean we're not doing anything. It just means there aren't any recommendations that have yet been published. Some 10 years ago, there was a lot of discussion to say that medication can be interesting to target symptoms like emotional deregulation and so on. A lot of debate about that and discussions in the literature in the 2010s. And then the Cochrane meta-study of 26 randomized double-blind studies over 2,000 individuals found no difference with regard to the different symptoms of borderline personality disorders. But that doesn't mean that these authors are going to say, well, so what do we do? And so it's perfectly possible and perhaps recommended to use antihistamines or quetiapine and so on. This can also help if, of course, you remain within the limits of these treatments. But the essential point of the therapy and the basic therapy is based on psychotherapy. And in all meta-analysis, this is what comes out. There's first treatment for personality disorders is psychotherapy. So this means that you need to have a therapeutic background and a framework. And that's difficult. Obviously, you can't do that the first appointment. You have to go into this gradually, because sometimes there are some memories that come back, and it means they can't sleep. And 3 weeks later, you said, yes. I said yes. And sometimes it takes a long time for them to actually spit it out. It's important, and I think everybody would agree with that. This is the paradigm. What I'm interested in with these patients is this is a paradigm of the therapy for addiction patients and management. It's not like in the classic medical model. You don't just give a treatment, just prescribe a treatment and it goes better. The paradigm is that you're going to help somebody to change, somebody with a personality disorder, and that's how it works. If you just impose outside treatments, I think this has been my experience, and no doubt yours as well, that that leads to a clash. And people say, well, your treatments just don't work, and everything you tried hasn't worked, so you're no good, and so on. This is the kind of reaction that generates. But of course, you do have to remain positive, and if you keep trying, you can succeed. You need to discuss the rules of this management, and to begin with, the framework is very often tested at the beginning of the treatment. Somebody will say, there's a kind of contract. If you can't come into the weekend because you've got your dog to look after, you say, well, come and see me on Monday. Because I know that when I've fixed this, made this appointment, but half the time they won't actually turn up. And when they come back, they'll expect me to shout at them because they didn't come for their appointment. I know that's going to happen. That's almost predictable. But that's the way it happens. There are probably good reasons for not honoring the appointment. But at least they're not functioning in a black and white way. There can be a space in which they can feel a little more free. So that also means that you need to find the right relational distance. Not too distant, but not too close. It's difficult. And the advantage is that as addiction professionals, we already operate in this way. The motivational approach, it's a technique. We're used to having this dialectic with our patients, and we lead the patients to see the advantages and the disadvantages of any given situation. And that's, in a way, how you can start discussing things with the patient. See, what are the advantages? What are the disadvantages? If you go to hospital, what are the advantages? And what are the disadvantages? If you don't go to hospital, what are the advantages and disadvantages? That means that the patients themselves can find the mechanism to effect their change. If you try and do it in their place, then that's where it's not going to work. Because they will always expect things to be done rather better. So the standard techniques And this means that you need to work in a network, and that's not as simple as that. We don't always have the same culture between addiction specialists and psychiatry. The most recent example in psychiatry, there are a lot of units that use a lot of benzodiazepine. I've seen cases recently where the patients have been in hospital and they've got 2 benzos. And I say, what am I going to do with them? So that's one of the challenges with these patients, is to find a reference practitioner who's going to look after them, somebody they're going to trust, and is going to establish a more or less stable relationship with them. And the others, as part of a group, I think taking on a patient like that on your own, these borderline people, is difficult, because you will also have your ups and downs. It's something which is pretty hard to deal with. You have to be aware of your limits and have support where you need it, because otherwise you're just not going to be able to survive. So it's better if you can work, and I'm going to move on to my conclusion now. If you want to take it any further, there's a very fine document on the Psychotherapy Association on that subject. I go through to the discussion and the conclusion now. Psychotherapeutic management is going to be, first of all, developing capacities in the patients to adapt, strengthening self-esteem, to emerge from crisis situations, improve social skills, help their patients to recognize their emotional states and see what depends on them, what depends on other people. And if you want to take this further structurally, then there's a lot of discussion at the moment, but I think the therapy that comes out as the most effective at the moment is the Leinian dialectic therapies, which is not yet very developed in France, and the therapies of schemes or patterns, which again is something which has its place in classical psychotherapy, and it's very appropriate. So just for the last thing, this is, of course, all the artistic dimensions, everything goes through the body, feelings, artistic expression and so on, can be very useful. And I've got a picture that shows you, and I thank you very much for your attention.
Thank you, Professor DERVAUX, for this presentation, which was very, very interesting. It's a very important point, because in order to work in the field of addictions, we talked a lot about personality disorders, borderline personality disorders, and it's interesting when we look at DSMs. To DSM-2, there was no diagnosis for dependency. When you look at DSM-3 in toxicomanics, it is characteristic of personality disorders. What then was seen in psychiatry as a personality disorder was seen as negative, and what you said before was, not only should we think that borderline disorders should be an addiction, also has a positive diagnosis. And if there are any questions, I'm from the generation where we talked about security bases in psychotrauma to broaden post-traumatic stress, not only the current definition with a traumatic event where we were fighting for our life, perhaps a rape, but many lot of work which is carried out with soldiers. They could have the same type of symptoms, soldiers, without having been directly submitted to that anxiety. They were chronically abused, and the hypothesis, it was a woman in 1982, was to think about extending this concept to children who could have suffered chronic abuse without necessarily having to be sexual aggression. And so this post-traumatic stress disorder was broadened. And with using different terms, something which could have been intrinsic. When throughout your childhood you criticised, someone said that regularly their parents put them in the bin. There's no rape or she wasn't beaten, but psychologically it is abuse. It could also be something that you've seen suffered by others. I had a borderline patient, and several years after psychotherapy, when she was small, one day her grandfather, he was completely drunk, put his daughter in the oven. And it's the kind of things which emerges. This is something that she saw, she was witness to. And it took years to express this. Thank you. I'd now like to continue. We'll have a debate at the end. We'd like to move over to Léa MONTAGNIER. While Léa is connecting her computer, does anybody have any urgent questions? What we were saying as well, the consequences of care in the field of addiction and personality disorders. Medicines have a role, but the key is much more support to help people change. The medicines are there to help. Over to you, Léa. Good afternoon. My name is Léa MONTAGNIER. Before we go into the details of the presentation, unlike my colleagues on both sides, I'm not a medical professional. I know psychiatry very well, but my background is in communication and argumenting, and I work at the Federation of Addictions and I pilot the Psychotraumaddicto project, which I'll talk about in a minute. So we won't go so much into the clinical and scientific data here. I think have already been mentioned, but I want to look about the materialization of this project. The first initial data, we're talking about the initial lessons in terms of quantity and before, and now we're going to look at the quality. Psychotraumaddicto, what is it? The title is rather explicit. Based on a double consensus, increasingly in the medical community, we can see that post-traumatic stress disorder have predictive and the risks linked to addiction are taken care of. This is what Jean-Michel was talking about. The challenge that we saw this before this project. The aim of this project is in this subject, what we were able to see from the field is that we were aware of the link between TSPT and TES, the use of substances. So what do we do about this? How concretely on the field can we implement this? How can we materialize it? And how can we ensure that our practices include this awareness? And on several levels, in terms of knowledge, disseminating knowledge, the organizational method, with this single structure, the transversal cooperation. This was a request by professionals themselves. This is the only figure I'll give you because we don't have the after figures yet, but we work with many professionals on these subjects. A study was carried out where addictology professionals, 55% of disorder identification, and even beyond we had 40% who said that sometimes they had to ask questions to the patients about their disorders. In terms of psychiatric professionals, 40% didn't use substances, and here it's more to do with transversal knowledge of addictions, but not necessarily of the tools, of the criteria, of the scales, and the evaluation. So the objective of this project was obviously to improve the diagnosis of those concerned. And there are two sub-aims: bring together different fields of expertise, and also to develop tools for professionals by professionals. This is what we tried to do. We're not from a top-down, we don't have a top-down objective, but it's more about collaborating in a positive manner. In terms of the method, we have several. In the beginning, we had the strategic piloting and coordination, which was done by the Addiction Federation, partly by CM2R, who were unable to come today, and the Centre of Resources for Resilience, which is an institution which was created quite recently, linked to post-traumatic trauma. And there are 3 regional sites which are specialized in addictology: Saba and Carud, and the CRPP. These are these regional centers. In parallel, we have carried out scientific and methodological work, which I will present in a minute, and which is led by a scientific committee, bringing together field experts, research experts, to come up with works which will be primordial. And this is, and there will be quantitative and quantitative evaluations by the hospital centre in Clermont-Ferrand. And this is to identify the progress in each of the sites in practices, and the terms of quality, to examine how the project impacts the practices of professionals, and look at other expectations which may exist. So these are 2 works which are in progress. Before we look at the lessons learned, there were 2 resources that have been produced, or that are being produced. The 2 main works in this project which will be disseminated. So mainly the work on deployment for these two works. We will have the practical and theoretical guide, and this was written in collaboration with the scientific committee. This guide aims to be structured in the form of questions, 3 main sections, and the aim is not really to review the literature, even though this could be interesting, but rather to translate it concretely based on specific cases. Our aim creating this work is to be able to talk to people who are vaguely familiar with the field or with practitioners, but we wanted to stay practical, and this is why we came up with this questionnaire format, and it's adapted to the field. For somebody, for example, who doesn't have the time to read a 50-page guide, and that will enable them to go directly to a particular issue that they're interested in, and giving them the tools that they need and how to implement them. There are obviously scientific references, but there are also practical case studies by participating professionals. We want to have both an objective overview of what exists and to provide insight into professionals who really master this subject. To show, for example, this is how we do it, this is how I do things, this is my opinion, to inspire people. There are 3 main parts in this guide. How can we understand the multiple aspects of this? The first part will be to go more into detail about the about dual disorders, the trauma and the use of substances. The aim of this part is to provide keys for understanding, and the second part will be on identifying, with its 3 stages, identifying, diagnosis and treatment. We will go into this in detail. We are also developing, we're trying to look at the carer's role and make available the tools, the scales for diagnosis, and the way that they can integrate this into their work. And we also review therapies, what they involve, especially diachronic, synchronic, what this involves in terms of the therapist's perspective. And the third part is about care, where we talk about the therapeutical objectives, how these are defined for who, and also the conditions for support. This will describe the different types of treatment that are available with suitable advice, where people aimed at people with different roles, and it's almost like a decisional tree, which will enable you to have the right reflex and tools to deal with the reality as it is. There's not the idea is to always have solutions at hand and to help professionals use these tools so that they can, they're not completely lost. Often there's a lot of information for carers, and this is what we explore in the guide. The second work is the networking guide, and here I won't go into as much detail, but it's a guide handbook, which it's a shorter handbook about how to create sustainable links with structures. It's a guide interested in actions which have been implemented by the pilots I was talking about with the evaluations. Did such and such an action work or not? Would you recommend it? Why not? And there are solutions for professionals who want to create links so as to deal with dual PTSD, and in terms of lessons learned and good practices, inspiring practices. These are things that can be applied to other organizations or institutions. There will be the do's and don'ts, advice from professionals in the project. Tools will be provided, and training modules which have proved themselves for patients, training supports, which can also be for institutions who would like to become more involved. Let's take a look at the lessons learned. As the guide, both theoretically and practically, as Jean-Michel said, I want to refer to to be more of have more of a coordinating role. The project finishes in December 2023. So what have we observed in the different sites? What works? What more overall solutions exist? The condition for success, number one, is to have a shared language, because we realize that very often there are terms like reducing risks, and in psychiatry it doesn't necessarily mean the same thing. But so the realities are not always known or detailed. So from the very outset, there was a wish to harmonize everybody's knowledge, to enable us to exchange more. Of course, if we don't speak the same language, how can we discuss things together? Even if, for example, I don't speak Spanish, so the way we implemented was we had across training days, we had workshops to exchange and debate key notions, and a shared digital space for literature and scientific resources. And all the participants in the project had access to this. I give them access to the works which will help them learn their own lessons. The second condition for success is to experiment with the partners field. This can be quite complicated to implement because the human resources available are limited. And also, as part of dual disorders, in psychiatry in general, since psychiatrists, we have psychiatrists who come who have very different problems. And so we need to concretely observe what's happening and to see how a consultation takes place, how it's managed with the specialized team of practitioners. So this huge diversity of profiles and requests means that we have this need to see how in practice, in terms of the clinical table, what we observed with the patient. As Alain said, we're not always faced with caricatural cases. We have to diversify time given and regular exchanges. It could be once every 2 months, once every quarter, but to exchange about an addictology patient, a psychiatric patient, and to see what the different views are and try to bring these together. And finally, the third condition for success, which may seem common sense, we need to think of bespoke solutions. In reality, there aren't ready off-the-shelf solutions. On the three sites and our teams, we have a huge amount of geographical constraints which are not the same. For example, two which may not be in the same building, they may be 50 kilometers away. The specialties practitioners which are not the same. And in addition to theoretical knowledge, we need to observe and see what's missing. And this is something the different sites that we work with have developed general solutions, almost generic solutions, that everyone can use, but in reality, it's very complicated. And these solutions didn't necessarily satisfy other sites' issues. We need to see, what's the barrier that exists between them? What can we develop together? And things are beginning to move forward. We have lots of different ideas, and that's what we want to share. We had specific trainings in methods. We had work mapping, see which professional is needed. We need to develop educational therapeutical tools to, for example, to manage the patient's emotions. Regional days, which are organized because there's an increased awareness. We need to involve more professionals. And that was my last slide. Thank you very much. Thank you very much, Léa, for that very inspiring talk. And now we're going to wait for these documents. Thank you for your personal involvement in this project and for your dynamic attitude. It's not always easy on the field. George, we'll just wait for George to set up his computer now. And we'd like to thank the organisers of ATHS and Jean-Pierre for having invited us. I've known Jean-Pierre for many decades now, and he's always ensured that there's it's been there was often the temptation to hyper-specialize, but he kept things seamless. And we're now going to look. Jean-Claude was one of the driving forces. So George is now going to talk about hyperduality and dual disorders for tomorrow, perhaps for the distant future as well. He's President Intelligent at Clermont-Ferrand. Thank you very much, all of you. My name is Jean-Pierre. I thank you for the possibility of giving this symposium, and thank you to all of you who have come here today. I want to look at what's been said and try to synthesize this and see what solutions exist for tomorrow's world, as Jean-Michel said. To provide recommendations for tomorrow, we have to look at whether we really understand this relationship between traumatism and addictive pathologies. How does it work? We need to better understand the current situation. We're talking about comorbidity. Historically, comorbidity is the association of disorders, but in psychiatrics, it's the association of one mental pathology with an addictive pathology, and the frequency of addictive disorders is very high, and the frequency of mental pathologies who suffer from addictions, it's 40 to 50%, and these are even more present when the disorder is at a young age, or for example, when in a prison environment. What we talked about, this hyperduality, there can be other underlying characteristics, previous traumas that have been experienced, or the field of traumas that's underlying and which creates a support which is favorable for addictions. In the literature, we can see, for example, people with opioid addictions. We know who they are. Very often, for example, it could be young women who have been subject to violence during their childhood. Duality is more than just adding two things together. The definition of Michel Casas, it's a process of associating which includes synergy, negative modification of symptoms. What's complex in this hyperduality is there are many symptoms, and it's difficult to look at things precisely. For example, a bipolar mood, schizophrenia. We have symptoms which are post-trauma disorders, but very often we don't have the disorder has not been clearly identified. Very often, the delay in terms of diagnosis, there's a delay in the diagnosis, and this association is often expressed not by adding symptoms together, but hidden symptoms which are additional with modifications, emotional dissociations, which are a way of expressing disorders, which makes diagnosis more difficult. In the current care system, we don't always have integrated, coordinated systems that provide care from a psychiatric centre or institutional centre, as Alain was talking about this, with borderline personality disorders. It doesn't require hospitalisation, and so it's very difficult to support patients. We need to keep supporting them, and we'll see in the recommendations. We talk, for example, about shared coordinated care and perhaps in community care. Very often, by institution, the trauma is a link which brings together the addiction and very often, so these are have more than two pathologies. The function of drugs. Why do they take substances? Because they have a vision. The consumption of these provide there's a relief for the patients to improve social interactions, to improve sensorial reactions, but drugs generally act to relieve not only physical pain but also psychological pain as well. It can help reduce stressful effects, and this helps patients go from one mental state to another, which is perhaps less unpleasant. And this is something that they experience in their own flesh. It's not only narrative, but it's obviously sensorial. It's something that they experience, and they're looking for substances to relieve the physical symptoms. And this relieving function is something that they turn back to. It almost becomes an automatic reflex. And the models which we use to understand the relationship to trauma, stress, and addiction is we have this model which over time, as we develop sensitivity for repeated mental illnesses, as they counter stress, our patients, there could be mood disorders or post-traumatic. It has a snowball effect. The quicker the pathology is expressed, the more the substances relieve. Or it's, as we said, it's to provide relief from confrontations with stress, from stressful environments. And there's a loop which is inescapable. Stress, hypostasia, certain psychopathological situations, post-trauma, with a return to the reappearance. And it tries to stop the symptoms reappearing, but then it becomes a vicious circle. In this stress model and the appearance of the mental pathology, what is there? We got to go back to the basics. In this rather traumatic period after the recent rugby matches, let's go back to the basis here. Trauma is not stress. Trauma is something different from stress. Trauma can occur in stressful situations, and very often there is stress present. There are traumatic events, for example, but trauma is a confrontation, as the purists say, linked to something where you could have died, or somebody else could have died or lost their life, or they could have been seriously injured. So here there's a major event which in the individual's system, they don't have anything to hang on to. Very often the traumatic event is huge and it's unexpected and something that shouldn't have happened in the patient's life. That's what trauma is, And that's how we should look at it, and that should enable us to better treat patients. Of course, for everybody it's different. We need a broader description. Trauma, it's the history of a traumatic event, of an important traumatic event, with, for example, encountering death or a situation where somebody could have died, or be severely injured, or sexual violence. There's also the possibility of having events which are described by somebody else. This is new. It's historically not everyone agreed on this, because you could be traumatized by something that somebody else experienced, something that you were witness to, and here you open up the field of trauma for something which perhaps you didn't experience yourself, something you were witness to. It's what we'll try to get from our patients, of course, is the symptoms. You know the symptoms, whether in the day, whether at night, nightmares. It can be very handicapping for patients. For those dependent on alcohol, it enables you to annihilate all these nightmares, these intense nightmares. It leads to pseudophobias, traumatic pseudophobias. Patrice, do you remember that? Oppenheimer? Oppenheimer had a railway accident and was terrified of trains, without necessarily having to go back to the place where the trauma occurred. It could be cognitive, it could be dysphoric. Those emotions linked to experience, an experience that they've lived through. Hyperactivity. For example, having a sudden jolt, your telephone rings. It was said that the presence of an addictive pathology favours the presence of trauma and vice versa. If you consume alcohol, then you have the greater risk of a fight, greater risk of an accident. As this was presented in 2003 by Breslau, the relationship between traumas and addictive experiences. These are risk factors for developing addictions. All the patients have to be assessed for the possibility of addictions, and the personality traits, for example, impulsivity, can be behind traumatic events or addictions. According to this paradigmatic model, we could have initially the trauma and the disorders from usage. We have personality disorders that emanate from this, but also childhood traumas and personality disorders. So the relationship between trauma and addiction is very complex. It's very difficult to be in a relationship of causality. Very often we're in support, a living plan which was favourable to the emergence of both a mental pathology and a traumatic pathology. These models were presented by Michel Lemoine, who is a grandmaster in addictology and manage to theoreticize the environment and the future of the individual when faced with Michel Montaigne says that the brain is made more fragile historically by childhood lacks, and it can also be made more fragile by the consumption of substances where you lose your awareness. And this explains the childhood fragility. Beyond the trauma, if repeated more than once, especially child traumas are repeated again and again and are behind traumatic experiences which regularly affect our patients. These complex traumas are more than just simple traumas because beyond the symptoms of giving a feeling of threat or addiction, there are also factors such as the manifestation of personality disorders, negative care orders, and difficulty in maintaining interpersonal relationships, and this complex trauma by Mercredi, which appeared last year. We can see the link between complex trauma and a borderline trauma disorder. We can see the distinction between, which also appeared last year, the borderline complex disorder means this in the borderline characters' relationships are characterized with others in a more volatile way, and the modification of interactions with patients, between patients and their environments. It's worth noting that borderline personality disorders are the expression of a traumatic situation and was the support in this modification of the personality. We also have neurobiological aspects which could also explain the occurrence of addictive pathologies. What should we now do? We need to, as this will be developed in both handbooks and works that we're going to produce after the study. The material is, we're starting to have material now, is to propose ways for identifying. We worked in this project on. We need to identify to treat for addictive pathologies, and the opposite case as well, trying to avoid addictions. But if we look at 2/3 of patients, how can we ensure that we better identify and diagnose trauma and post-traumatic disorders? We need to focus on populations which are perhaps at risk. We need to identify populations where repetition occurs. Addiction is repetition. Trauma leads to addiction. And there are certain populations who are more likely to be subject to this. With the recurrence, the repetition, when there's something which is linked to a repetition, or you think that they're always saying the same thing, you need to wonder what the underlying subject is. We have had subjects with precarity. I've had many patients, and this data from 2001, you can see the prevalence. It's on the right of the middle line. It's a higher predominance of post-traumatic stress and people in a situation of not having enough money. The traumatic, the link between precariousness and mental pathologies in populations which we saw before are very often precarious. There's still a lot. We still need to look for the addiction and the link between addiction and pathology. We also need to be careful with signs given by patients about their history, the way they come to us, things that are not said in the relationship, which can suggest a presence during childhood. In the childhood, there was these difficult childhoods can lead to addictions in teenage years. We talk about the possibility of trauma. For example, sleep-related disorders, the fact that people don't sleep enough and they have nightmares about events. In the history of the nightmare that's being told, very often you can see the trauma that has been experienced, and of course there are signals, other signals in patients. So we can ask a question, for example, where have you experienced a traumatic event recently? I think we need to ask this question. Very often we don't get the answer immediately. Or perhaps they don't want to answer us immediately, but nevertheless these are very important things for us to do. The traumatic event goes back to the person's own experience that they talk about. We need to identify, diagnose with screening tools for post-traumatic stress, with certain scales which are being developed with questions, which can be guidebooks, support to ask questions, so it's in the therapeutic duration we can identify traumatic events. We mustn't mustn't affect the ability of patients to be in a relationship, and we need to show them where they are in that scale. These tools can help us look at some things with patients and to give meaning, to clarify a certain number of symptoms which they may be subject to. We have different types of tools here. Post-traumatic stress checklist scale, for example, the impact of the event, and it's all these scales are to identify and are then confirmed with symptoms presented before. Stress, the jolting. How can we intervene? As Léa said, and I want to go back over that, we have intervention players, we have people in psychiatry, we have addictology, so that's something that should be opened up. And we try to bring people together to have a coordinated approach and integrate the support for psychiatric care. And when this is not present, we need to be able to find ways of articulating work done together. We need to look at the trauma is a very important criterion which occurs in an individual and something that they will have to live with forever. Trauma is diachronic by nature and transforms the patient's life. Nothing will be as it was before. This is something you have to deal with on a daily basis. But at the same time, very often there are events which bring out the trauma, things that happen in life. For example, meeting somebody in an amorous relationship, for example. It could bring out pain, but there's also moments that we can seize. Trauma is part of the common language, and today it can mean a lot of things. So we have to be very careful when we're talking about trauma. We have to be able to listen to it. I think everybody can do this. You need to be careful in what the image that portrays everybody. And this is it's a question of being fascinated. We very quickly need. We're often trapped by the story told by history, and something that's very painful, that's incredible, which will sometimes means that we're too kind of ingrained in the daily problem. We need to work on fascination and identifying this, and perhaps say, why was this done this way and not this way? Why even a judge, for example, was they in a traumatic relationship? It's very frequent in a rape, for example, that patients they were not able to call for immediately for first aid. We need to disseminate knowledge about trauma. We need an appropriate space to discuss it. It must be a protected space. It could be, for example, in a hospital, but we don't force people to talk because we know the trauma behind this. So we've in our services we see many people who ended up by saying, when I was a child, I was raped by so and so, and once people hear that, people think things will be better. But sometimes the opposite can occur. So you shouldn't think that something that's said is kind of a relief. We need to respect, give people time to speak. So we need to listen and listen and listen. We need to listen more than we speak. That's the #1 rule in psychotherapy. Listening is enough, and perhaps the by not expressing this, it can validate the suffering of the other. We need to. We shouldn't validate the suffering. We need to. In addictions, trauma often use the same words time and time again. And it's this repetition that we need to look at. In order to treat traumas, we always need to start with the user. If they speak, we need to listen. If they don't speak, then we shouldn't force them to. It's the subject who describes the trauma, and if they say the trauma, it's their trauma. Sometimes it's invented, but it's always the trauma of the subject. But then the therapist can say whether it's a post-traumatic disorder. We would say, yes, you have your trauma. France lost the World Cup. It's your trauma. It wakes me up in the middle of the night. If he'd kicked on the left, so be careful. You can see there's studies that have been carried out. When it can be treated in the hospital environment, outside the environment, if it's suicidal, if there are psychotic elements as well. A very important point is working together as a team. It's a multidisciplinary approach with social workers. Everybody needs to participate in this. Sometimes the psychologist has heard about a trauma, say that the patient doesn't want to describe this. And we can share a story of course. This enables us to construct something, but we always have to respect the medical secrecy. We need the community-based approach because this is something which will last over time. Traumas are diachronic. We have to help them live with this, and the same with addictions, and it will take time. The approach must be integrated. We can add different treatments together. We focus on the trauma. There are the psychotherapeutic. The more we would concentrate on the trauma, the better. So we need to work on the trauma in dialectic way. ECV. And when we look at life stories and when we look at how we can position the trauma, we can see that there's often in addictive therapies, we need the motivational approach, therapies in 12 stages, behavioral treatments. There are factors which limit the patient's resilience. If the trauma was very early on, if they can't mentalize the trauma, then it becomes more complicated. So we need to appraise the situation. The treatment, if we in terms of we have cognitive behavioral. Should we do a progressive exposure, therapies by exposure, step by step, no immersion, which can be efficient, and then there's MDR interventions. But one very important point is that we should never expect we should never expect for the patient to have left behind the trauma to start treating it. We need to deal with it immediately. The substance, of course, can limit the ability for treatments because psychoactive substances cut off the traumatic images. They block them, for example, by opioids, by alcohol, and all these block the traumatic images. And by blocking in the amygdala the trauma, they block the image, and they have no prefrontal cognitive ability to deal with this. And this is all part of the process for resilience. And so if we can't have a cognitive resilient treatment, then it keeps coming back. We can't manage to deal with it. So we'll start with this, with the medicines. The final aspect for me, for homeless people, we had pharmacotherapy. It was the physical and safety and the ability to have choices. The more we support people and the more we work as a community in our support, the better. This is a message of hope. It's not a question of being a psychiatrist. We need to provide the correct support as a community. All those involved. And it's this common support, shared support, which will help people to position themselves in terms of resilience. Thank you, George, for your presentation. We'll think about the therapy that you require for the rugby match. see whether it's a brutal immersion. We have a little bit of time left. Are there any questions that you would like to ask? I'd like to thank you for the quality of your talks. And in terms of trauma, intuitively, I've always said in the prison environment, the prisoners, there was only 6 months left. And some people we know in the penitentiary environment that there was an addiction and post-traumatic disorders. If the patient starts to talk but doesn't insist, my question is, you said it's important to be there. What happens if you can listen but you can't follow up because the networks are not structured? Is it the right moment? Is it the right moment? That was my first question. Second question, the prevalence of these dual diagnoses for incarcerated populations. Is there anybody any of you who work in prison environments in terms of psychoaddiction? My second question, and my third question on mesapine. Why is this very specific? How does this specific product work? For the prisons, somebody who's imprisoned, we talked about clinical, there's an overrepresentation of people with borderline disorders. It's obvious that in prisons, we have an overrepresentation of those who have impulsiveness, personality disorders, addictions, etc., and who've had a traumatic past, or that they've been witness to traumatic events. So, from a certain point of view, it's the idea of a project we have for. We were asked for ideas about addictions. One of the things is to identify post-traumatic disorders and to look at what solutions could be given in terms of addictions. We have people in the group who intervene in prison environments, and so this is a good possibility. When we look at the increase in the use of tobacco, for example, migrant populations, which George was saying, we know, for example, from the Paris authorities, there's massive disorders. The fact that they're constantly moving from one place to another, the children are completely disoriented. The fact that they're moving from one place to another, then they don't have a sensation of being safe. And this is one of the challenges which is underestimated. And one of the places, and so yes, even this population as well, there's an overrepresentation. So perhaps mirtazapine is both a complex molecule and its versatile action. All the products which reduce the level of stress, as l'oxytocin, are efficient on post-traumatic stress. So there are quite a lot of perspectives. Very often the molecules which act on the targets are actually the same. I just wanted to make 2 or 3 comments. Until proven others, metazapine, I think that it's very interesting. I heard that until now, even internationally, it's not prescribed for post-traumatic stress. For the previous talk, I appreciated the notion of trauma for the rugby match, but we need to make the distinction between SN5 criteria, the acute stress, the state of post-traumatic stress, and disorders of adaptation, which are different. Because trauma after an injury, we could have it without a psychotrauma. So I think this is an important question, because in the event of acute and post-traumatic stress, there's we're confronted with for example, when we talked about the defeat of the French team, we're not talking about life and death. We're just talking about a question of adaptation. It's not. I just wanted to make that comment. And thirdly, for borderline cases, I thought it was very inclusive, this notion, to say that borderline cases are often, I make a diagnosis when there's been a level of a trauma, an attack, a violent aggression. And it seemed that you're saying in the new classification, we can broaden the diagnosis for the states, for borderline states, to situations which don't confront the individual with a true psychotrauma. There are cases without post-traumatic stress. In the article, it's not necessarily one of the criteria, but it's something we find so often that we can, these subjects are constructed, and as this happens very early on, the personality will be constructed in these moments. It's not 100%. Thank you for your presentations, which are very interesting and very enriching. Darren Kavanagh from Créteil. I'm a psychosomatician, and I have a question about psychotrauma. What I understood was alcohol you talked about using drugs in general. Is there an explanation to say that alcohol is predominant and drugs by product? Are there any favourite substances? There are many studies, many old studies, and the classification has changed over time, and the diagnosis criteria. which PTSD criteria. There were different ways of apprehending PTSD over time. There are retrospective studies with the consumption of products, many about alcohol because it's very widespread. But we also have data for prisons with cocaine and all other substances. And all these substances can lead to PTSD, even if only by inducing the risk of encountering a trauma. And that's true for all substances, more perhaps for alcohol, but there are studies which show this. In alcohol, it's higher in men and in women, for example. So we need to be very careful when we use this data. There are phenomena, for example, for migrants, there are traumatic events which lead to the consumption of, for example, in wars. It's very frequent. There was that study which was as long as possible on British veterans who went to Afghanistan to see what they were like before, during and after the conflict. And we can see in the references, we can see in the study that traumas which were frequent in people who had with the consumption of substances with violence. It was more common after the operations. So there are risk factors, for example, with certain character traits. Let's take two final questions. There's also the offer. For example, in the 1940 war, it was alcohol that was available. The Vietnam War, with the Jesuits, is cannabis and morphine. The Afghanistan war, it was different again. So it depends what's actually available on the market. I'm a doctor. I'd like some information, more precise information on certain medicines. You showed some on the slides, which are linked to borderline cases, to adding treatments. For example, Topamax. You also talked about Topiomat. There are three substances which potentially have positive interactions for these patients. What is your opinion about these? Topiramac was effective to treat alcohol. Topiramat is prescribed to adult women. And what other molecules? Propranolol for acute stress. Propranolol was for acute stress, but it's also now being used for exposure therapies to limit the risk of PTSD. And there are now trials being conducted to better understand cravings. So use perhaps something that was for PTSD for addictions. For example, in many women, it's triggered by stress. So we have a pre-treatment which avoids the initial symptoms in terms of anxiety, and this can be used to cut cravings. And we see more and more the shared use of these molecules. The big advantage is propranolol, unlike a benzo, which is, as George said, freezes propranolol. A final question? it's not really so much as a question. It's more I wanted to react to what Bruno Millier said. Bruno, you're right. There are only 2 products in France that have the same paroxetine. There's those which are official and which are commonly used, and there's mirtazapine, which is for 15 years has been in a good position in the guidelines in the UK. The Japanese use this a lot in PTSD cases, and you're right to remind us of the acute stress and PTSD. And I regret that in DSM-4 there was the definition of exposure to the event with the A2 criterion, which is the reaction of a subject to confrontation with the event. When there's an event which can be objectively qualified as a traumatic event, there's also the reactions that different people can have. And I imagine that George, faced with the symbolic death of the French rugby team who were assassinated by what you felt by identifying something which could be assimilated with trauma. But he also was somebody at the end of the match. I said, that's the end of it. Let's stop there on that note of hope. In 4 years, it will still be the same. The revelation of Professor Bruce. Thank you very much.